Okay, we're going to be talking about osteoarthritis this evening, and I would imagine that's the subject that affects a number of you on this call. So without much further ado, I'll ask Dr. Wilkins to start and introduce himself. I'm sure a lot of you already know him.
Yeah, Dr. Carver Wilkins here. Thank you all for joining. Been looking forward to this for some time now. I'm an interventional pain specialist, which means I specialize in minimally invasive procedures to treat an array of pain conditions all over the body. I did a sports and spine fellowship after my residency, and there was a little bit of a focus on ultrasound guided procedures. And that really comes in handy if you're talking about treating musculoskeletal conditions outside of the spine. Ultrasound helps out with not only guiding a needle or other instrument, but it also helps in diagnosing a condition. I've been in practice now for about 11 years after fellowship. And in that time period, I've made a conscious decision to really investigate a lot of different non-surgical pain treatments on the market today. Now, some of these I consider to be kind of snake oil. They're not so good, but others like platelet-rich plasma or PRP, we'll kind of use those interchangeably tonight. They're fantastic, and they've made a tremendous impact for a lot of my patients. And Andy, not to spoil it, I know you've had some of these treatments yourself. I'll let you get into that if you want to. I'm not gonna steal your thunder there. That's up to you, buddy. As a whole, though, I believe we're just kind of scratching the surface on the potential with regenerative treatment attempts, treatment options like PRP, and there's others. So I'm going to for sure remain diligent moving forward. I'm very passionate about PRP. It's something I'm very, very interested in. And I really want to thank everyone for taking the time out of their evening to listen to this. I certainly hope you learned something. The next 10 to 15 minutes or so, 20 minutes could really be a game changer.
Thank you very much, Dr. Wilkins. And just to introduce myself, I'm sure most of you know Dr. Wilkins. So who am I? Well, my name's Andy Shepherd, and I've been involved with Orthobiologics, things like PRP, coming on for 15 years, so quite some time. I'm on the industry side. I supply the equipment and the training that's often used by folks such as Dr. Wilkins and Spine Team Texas, as well as some pretty well-known institutions across the country. I've been, as you mentioned, Dr. Wilkins, I've been successfully treated a number of times. One of the good things about being on the industry side is I have access to all the equipment and the physicians. So I certainly have had my fair share of these types of treatments. I found them to be incredibly useful. I've got all sorts of injuries from years of not being very good at sport, and definitely have hurt myself a few times. So PRP has helped. I'm a huge advocate of these treatments. I mean, the reality of them is we've got to a point with some of these treatments where they really are very, very effective. And the opportunity to talk to patients that could benefit from them is a gift, and I'm really happy to be here to support this. More than anything, I understand that osteoarthritis at best can be annoying, but at worst can be debilitating. It can ruin your life if it's left unchecked. And I'm very thankful for the opportunity to speak to you, really to help you better understand what your choices are, what your options are, what the treatments could potentially be, and help you make the right informed decisions to make sure you don't get trapped by some of the snake oil that's out there, and to actually work with the people that are doing it right, such as Spine Team and Dr. Wilkins.
Yeah. So, thanks, Andy. So to talk a little bit about Spine Team Texas, we've been around since about 2005. We have grown quite a bit since then. And right now we have about 65,000 patient encounters annually. We are spread out across DFW. We have 11 locations. We have 4 ambulatory surgery centers. We're a multidisciplinary practice, which means we have different specialists in our group. We have interventional pain physicians like myself. We have non-interventional PM&R physicians, and we have spine surgeons. It's the mix that separates us apart from the other options out there that are our competitors, so to speak, in DFW. So 30 physicians, we have 5 surgeons. That's a very unique ratio. And so what that does, it speaks to the conservative nature of our practice. We are 100% committed to treating patients as conservatively as possible. We are looking for non-surgical solutions. We reserve surgical options as a last resort. Now, of course, when it's called upon and it is required, we have very skilled surgeons. It's just that they even have an approach of let's consider all the non-surgical things first. Myself and my colleagues, we understand that pain can be quite complex. And, for instance, let's say you're looking at neck pain. Neck pain can actually be a shoulder issue. Let's say you're looking at back pain. Back pain can actually be coming from the hip and vice versa. Myself and my colleagues, whenever we're talking to a patient, it's really about uncovering all the different nuances of their symptoms. And then we want to offer the most cutting edge solutions in helping them get back on their feet. It's in our name, Spine Team Texas. I get it. It kind of labels us as one thing, this one trick pony, but I assure you guys, we treat a lot more than spine.
That's great. What an incredible operation. 65,000 patient interactions a year. I didn't, until we started talking, I knew you guys were big, but I didn't realize quite how big you were. And just to really make the point here, this concept now of leading with non-surgical options and then having surgeons as the backstop is the right way of doing things. And you guys have been kind of a leading light in doing that, rather than jumping to surgery early on, exhausting every option. And that's really important when it comes to things like osteoarthritis. Would you not agree?
Yeah, absolutely. We were kind of laughed at when we first started this concept of surgery as a last resort. It's not really the best way to make a lot of money, to be honest with you. So, but that's not what it's about. It's about getting patients back on their feet. That's really what drives us. So, to talk about arthritis in particular, that's a topic at hand. If you're watching this, it's either because you yourself have arthritis or you have a friend or a loved one who's suffering from it, who's been diagnosed with it. So what is it? Well, arthritis is really a degenerative state. It describes a wear and tear that happens in joints all over the body. It happens when the cartilage starts to wear down. If you look at these pictures here, these are x-rays, and you have especially you see the grade 0 or relatively normal knee, and then it progresses to a grade 4. You see how that joint space between that long femur bone and the tibia bone gets really, really reduced. You can even see some bone spurs that are developing there. That person would be having some pain. There'd be some swelling. There'd be some locking. And so that picture really accurately describes what arthritis is. We're going to be talking about the knee a lot, but arthritis impacts joints all over the body. The most commonly affected joints are the hands, the knees, the hips, and the spine. Shoulders are very common as well. I've treated every one of those areas with PRP, and I've treated them successfully, and my colleagues have done the same. So it's an opportunity for you you folks listening, regardless of kind of where you're hurting. If you've been diagnosed with arthritis, this could really be an option for you. If you have arthritis, we cannot undo it. There's no reversing the signs of arthritis. Okay, that's just an unfortunate reality. So the question of how can I fix it? We can't really fix it necessarily. We can't make those changes go away. But we can manage the symptoms. And that's where some treatment options come into play. But the idea of reversing it and getting you back to the way your knee or hip or shoulder look like whenever you're 20 years old, that ain't going to happen.
That's a great overview. Thanks for helping us understand what osteoarthritis is. So I'm assuming that most people on this call have osteoarthritis or have a family member that has it. What are the main symptoms that you're looking for when it comes to defining or diagnosing osteoarthritis?
Yeah, so that's a good question. So it could be really complex or it could be simple. You could have one symptom, you could have a myriad of symptoms. So the number one symptom is simply going to be pain. Pain is one of those other vital signs. It tells you when something is wrong. It tells you, hey, look out for this area. It may not be functioning as well. Very important. Pain is something we don't want to ignore. Stiffness is very, very common. As you start to get wear and tear of the joint space, the cartilage wears down, you get more friction across that joint space. That can create some stiffness. Tenderness along a joint line is very, very common. It just hurts when you push on it. Okay. You're kneeling down, it hurts your knee. You bump something, that hurts. That could be a sign of arthritis. Flexibility. Maybe you can range your joint not all the way. It's hard to get your joint through a range of motion. So it's not as flexible as it used to be. The grating sensation, it just, you almost feel it grinding. You can feel it bone on bone. Sometimes that probably is a more severe level of arthritis. You can hear the popping or the cracking, very, very common. In the hands especially, you can even feel some of the bone spurs because those are very thin skin joints. And so that's quite common too. You see these gnarly, knobby arthritic changes in the hands sometimes. And then swelling, of course, is very, very common. People complain of a swollen joint. It could be red, it could be quite tender, feel hot sometimes. Those are the main symptoms of arthritis. And I know some people out there are suffering from that right now.
A great overview. Thank you for that. How do you diagnose it then? So a patient comes in and they may have a variety of different symptoms. What tools are you using to identify or to rule out other things?
Yeah. So symptoms can be simple, complicated. So can the diagnosis. It could be simple or complicated. Very commonly, in addition to someone's presentation and their symptoms, it's important that you listen to the patients. I assure you that I'll listen to you. That's very, very important. We need to listen to our patients. X-rays are very, very common. That's kind of the first step. You want to look at the bones. X-rays do a great job of looking at bones. You don't see the cartilage between the bones on the X-ray, but you see reduction of that joint space. It was demonstrated on that picture, that grade 4 arthritis, where you see the bones closer together. MRIs are very, very common. It's a more expensive diagnostic tool. It's not absolutely necessary to diagnose with an MRI, but it can certainly be very helpful. Here's the X-ray pictures popping up once again. You see some bone spurs extending there from both sides of that joint. MRI, on the other hand, uses radio waves and a strong magnetic field. You get detailed images of the joint. You can see the soft tissue in and around the joint. You can see the tendons. You can see the ligaments. In the knee, you can see the meniscus, the ACL. You can see everything in an MRI, and that gives some detailed information, especially with complex cases. There could be more than one thing going on. And then, arthritis is the most common type of arthritis, but there's other types. There's rheumatoid arthritis, and there's something called gout, and that's where some of the blood tests can come in. You don't do necessarily blood tests for osteoarthritis, but if you have something like rheumatoid arthritis, and a rheumatologist would do a blood panel and test that accordingly. And then aspirating fluid from a swollen joint can be painful, or actually very beneficial as well, not necessarily painful, but can actually help you. If you draw fluid off the joint, it can actually help. But you would send that fluid off for analysis, and you can see crystals in there. And for those of you suffering from gout, I feel for you. I know that's painful, but that's probably how it was diagnosed, was with joint fluid analysis.
Brilliant, great. Well, okay, so now we know a little bit about what osteoarthritis is, and we also understand a little bit about how the symptoms and the diagnosis take place. Could you start explaining to us what sort of treatments are on offer, and how are those treatments delivered to patients to help them with their symptoms of osteoarthritis?
Yeah. So once again, I'll say that these things are not going to reverse arthritis. We're managing the symptoms here. So most commonly, perhaps, will be over-the-counter Tylenol, acetaminophen. It's not an anti-inflammatory, but it's good at treating mild to moderate pain. You do have to be careful with Tylenol. You can't take a bunch of it. It can damage your liver. So just know that. Very commonly are NSAIDs, Advil, Aleve, or naproxen. There's other formulations out there. And you have to kind of follow the manufacturer recommendations. There are different strengths out there, so be careful with that. With NSAIDs, you have to look out for kidney damage. So you got liver damage with Tylenol, you got kidney damage perhaps with taking a bunch of NSAIDs. You load up on them, you take too much at one time, you take them for too long a period of time. You have to be careful with renal impairment, kidney impairment. And then I also caution you out there, those of you that are taking blood thinners, you probably know this, but I'll say it again, you really shouldn't be taking NSAIDs with blood thinners. If you were to get an ulcer with an NSAID, if it starts to bleed, that could be a real emergency. And then the other one is duloxetine, probably less known. Some of you are probably maybe taking duloxetine on this call now. It's commonly used as an antidepressant, but it's got some evidence in studies that are showing that it's beneficial in treating chronic pain. So that compiles a good list of all the medications for treating OA.
Brilliant. So that's the kind of the oral meds that you might take. What about physical therapy? I understand that you have physical therapy groups that you work with. Where does that come into the mix?
Yeah, so we have on-site physical therapy at our South Lake location and Rockwall locations. We have very skilled therapists there, do a great job. The other locations, we like utilizing the community affiliates. We have good relationships with the therapy centers all around us. There are lots of them, as you would expect, in an area the size of DFW. Physical therapy, their real goal is to strengthen the muscles, the tendons around the joint. What it does is help stabilize the joint. It can help reduce pain, restore function, get you back to walking, doing whatever you want to do through physical therapy. Can be very beneficial. Occupational therapy is more about typically providing adaptation for you so that you can maybe offload a joint that has arthritis. Think about arthritis in your hands and maybe using a large grip toothbrush. Let's say you have arthritic knees or hips and you find you're interested in getting a bench for your shower or a chair to maybe offload the weight on your hips or your knees. That the occupational therapist can help you with that. And then lastly, a lot of you have probably heard of TENS units. It's an electrical stimulation treatment that sends a low voltage signal through some wires to some pads, and you simply just put the pads around an area that hurts, and you can use that for a period of time. And some people really like that.
Brilliant. So, okay, I think more extreme end, there are things like surgery, which we discussed at the start of the call. But there's also a number of injections that sometimes get used. Can we have a little look at them and how they work, please?
Oh yeah, yeah, and no doubt. I know you know, a lot of us have had these injections. If the other options are not working, you've got first line of defense is probably cortisone injections, steroid injections. Um, and they generally can help for a few weeks. I call it kind of a honeymoon period, where if I load you up with enough steroids, Andy, I guarantee you, whatever's ailing you for a couple of weeks, man, you
Feel
can
the thing.
buy go on that cruise, you will feel like $1 million. But guess what? You got to come off the honeymoon. And that's when you really see what steroids do in the big picture, which really isn't much. You got to keep repeating steroids. They are not going to fix it, far from it. And studies show repeatedly that if you get a bunch of steroids, they can be detrimental to the joint. And a lot of people limited about 3 to 4 a year, actually. And then, next, a lot of people have had these gel injections. Some people call them rooster comb injections. It's kind of formulated from rooster combs, apparently. Hyaluronic acid is another way to describe these, and it's about kind of almost like changing oil out on your car. It can reduce the friction across the knee, provide some extra cushioning in the knee. But head-to-head studies show that these injections are kind of inferior to PRP, when we'll get into that in a little bit, and some of them just aren't very beneficial at all. I'll be honest, I've done a lot of these injections. I did a lot of them early in my career. I did hundreds of them, and it didn't work. I haven't done any in years. And so that's just the honest truth. A minimally invasive surgery is called an osteotomy, and the goal is to offload a painful area of a joint, maybe shave off part of a bone, and that's for those conditions where maybe you don't need to replace the entire joint, but just maybe a partial, more mild surgery. Maybe that comes into play. Last, certainly not least, are the joint replacements. These are the big boys. These are the big surgeries where you're replacing the joint with either plastic or metal parts or a combination of both. And this is everything that a surgery entails. There's risk of infections and blood clots and malfunction of the hardware. Sometimes you need revisions. It's a major surgery. There's no other way to look at it. And it should be reserved as a last resort option.
And that's absolutely the point, isn't it? You want to preserve what you have for as long as you can and keep it functioning, keep it working before you have to rely on having artificial parts put in. Not that they're not effective, but if you can survive without them, then ultimately that's the whole point of this.
Yeah, that
So
is.
in a lot of ways, the real point of this meeting was to discuss those other options, right? We've covered kind of the traditional stuff there, what you would get probably if you went to Spine Team or probably somewhere else. But what really sets Spine Team apart is this kind of the fact that you guys have embraced these products called orthobiologics, which is a bit of a kind of a catch-all term for things like PRP and bone marrow treatments. Can you tell us a little bit about that?
Yeah. So we've been doing these for quite a while now, for years, and the point, like you made, is it's tonight we're talking about the other option or options. And I know a lot of folks have tried the therapy, they've tried the TENS unit, they've done all the pills that are listed there, and probably some others too. They've done shots, they've done the gel injections, and they've probably talked to a surgeon. They've been offered the joint replacement surgery. Maybe they're not a candidate for doing the joint replacement surgery, and so it gets very discouraging really quick. And people can kind of feel helpless. They don't know where to turn. and maybe you just quit seeing doctors altogether because you feel like there's no point. And I'm just here to say that there is the alternative. It's called, platelet-rich plasma. It's very accessible, and we treat a ton of folks with it, all different conditions. A lot of my arthritic patients are really loving it.
Brilliant. If you could you talk us? So, I mean, we talk about platelet-rich plasma. You and I know what it is. How would you best describe it? What is PRP?
Yeah, PRP in its simplest form, the goal is to maximize the body's healing potential. It's a treatment where we would draw your blood. It's a blood product. So, and it's your blood. It's no one else's blood. It's your blood. So in that sense, it's the safest stuff you could ever put into your body. It's minimally processed, which really is the reason why it's not even, it's not covered by insurance, because it's not really considered a drug. It's not processed enough. It's just concentrated. So we would draw your blood at one of our locations that across DFW. We also have our surgery centers where we do this treatment as well. But we draw your blood and we simply concentrate it down to the platelets. The platelets is where all the magic happens. And it's really important for us to understand what platelets really are. It's platelet-rich plasma. And so whether we realize it or not, we're all really familiar with platelets. If you think about all the times in the past where you got a little cut, you got a little scrape, you get a few drops of blood that form on the cut, and then it kind of gets sticky. Platelets are what that's a sticky part of the blood, the platelets, and then it forms a scab. And so fast forward days to a few weeks, that scab falls off, and you look underneath it. Voila! What do you know? That cut or the scrape is no longer there, and we take it for granted. This has been happening repeatedly, year after year, in every single one of us. And it's the platelets that really allow this to happen. The platelets are facilitating this. The platelets, inside the platelets, are these growth factors. I'm not going to bore everyone with what the growth factors are. There's a lot of them. They all have separate little roles. They're like they get their marching orders and they do what they're meant to do. And they do it very, very well. They do it for every one of us, whether we know it or not, for all the different injuries that we sustain.
So it's essentially, the platelet has the medicine inside it. That's essentially what you're harnessing.
Yeah, so it's platelets, but it's also something else too that we need to kind of get into. Platelets can't do it on their own. There's other cells in the body, and it's important that platelets recruit those other cells to the injury. And those cells, I'll go ahead and kind of name them. We call them stem cells. And so a lot of people, individuals, know what stem cells are. They really are the workhorse of this therapy, but we have to signal them through the platelets to recruit them to an area. They work their magic. They heal an injury, and it's all about reducing pain, restoring function. That's what this has the potential to do.
It's incredible. Yeah. So it's the platelets, and then also the fact that they send off alarm bells and get the body to send in other cells that kind of repair stuff, right? So that's really easy to understand when we're talking about a cut, because you can see it. But how does that translate to inside my knee, my hip, my shoulder?
Yeah, it's a little different there. So we're talking about a few drops of blood on the cut, but in a knee, we need a little more blood than that. So 60 mLs of blood, if you can picture that, that's a good starting point for drawing blood to do this treatment for a knee or a larger joint. 60 mLs of blood sounds like a lot, of course, but let me just give you a visual for folks out there that are kind of freaking out right now. 60 mLs of blood is about the volume of a golf ball. So it's not that big of a deal. And so with that, we're able to concentrate the blood down, and we get billions and billions of platelets. Somewhere around 12 billion platelets if we're starting with a volume of about 60. And from that, you get the growth factors, the healing properties inside the knee joint, and it helps really restore function to the joint. In pain reduction, it can get you back on your feet.
That's incredible. So, we understand that the platelets are pretty critical in helping us. And the question, I suppose, becomes, what proof is there? Have we got any clinical data? We could get any clinical studies that kind of show us what we could expect as a patient as for having an injection for these types of treatments?
Yeah. We can talk about a few studies. Let me just say that every patient's different. Everybody's going to get a different response to whatever treatment we're talking about. We're talking about PRP, tonight. Nothing can be guaranteed, but there's no doubt that it can be a great opportunity for those folks listening. There's variable results, is what I'm trying to say. The study one study we need to talk about, if you want to show a slide, is a study by Dr. Chu. He looked at over 300 patients. Actually, okay, go back. I think you're talking about, this is Dr. Bensel's study. Let's talk about this one first. There's two groups of patients. There's 75 in each group. And he compared the PRP patients to the gel injections that I mentioned earlier. And in the gel group, they kind of plateaued about the 3-month mark, then they reverted back to their pre-treatment state. So it really didn't work beyond 3 months. That's not very good, because these treatments you have to do typically, you can do up to 3 of these injections in a short period of time. If insurance doesn't cover them, they're not cheap. So you really need to get more than that out of these gel injections. The PRP group, however, was still showing improvement at the 12-month mark. And so that's pretty compelling. It doesn't carry near the risk of the gel injections. It is your own blood product, like I mentioned, doesn't get any safer. And so to get that kind of response with a simple injection, to me, is a good selling point. And this particular study utilized a product that was harvesting or processing down to about 10 billion platelets. The kit we use at Spine Team, we're at 12 billion plus. So, and I know it's a hard concept to imagine, but more is better. So let's go for the 12. Okay.
Everything needs to be bigger in Texas, right? You gotta go over.
Hey, this is Dallas. Come on. Yeah, another study is Dr. Chu. It's a bigger study, 300 patients in each group, large study. They used a similar kit, so it's more relatable to us. Their processing kit also concentrated down to about 12 billion platelets, just like ours does. And they compared PRP to simple normal saline. And importantly, they showed that the PRP group had great outcomes extending from 3 months all the way out to 4 years. And then MRIs on those individuals compared to their peers showed about a 50% reduction in cartilage loss at the 5-year mark. That's pretty compelling.
That's incredible. So we're beginning to see that PRP may slow the progression of osteoarthritis.
Yeah, that's probably one way to look at it. The way I picture it, the way I describe it to patients, is what it does at the absolute very least is it changes the environment from one that's more degradative, it's a state of deterioration. That's what arthritis is. It's a one-way street. I've already said that. You're not going to reverse it. Okay, one-way street, deterioration. It puts a stop point in that process. It can for a lot of folks. So it halts the deterioration. It converts it over to a more restorative state, a regenerative state. So it really changes the biochemistry of the joint. If it does nothing else, that's a key component.
Incredible.
These studies also just looked at knees. So that's another thing. So that, there's other studies looking at hips, shoulders, ankles, fingers, you name it. There's more studies now.
We made a conscious decision not to make, we could spend hours talking about the clinical data, and we could probably bore a couple of you to death. So we really were conscious that we didn't want to do that and give you a very general overview. And that's what we're going to talk about now as well. It's not just clinical studies, and that's not necessarily always the best way to get a gauge on how effective these treatments are, right?
Right. Yeah. And so there's another slide if you want to show that. It was put together kind of in a survey format, looking at 6,000 patients that were treated with the same product that Spine Team Texas uses. And the key takeaway here is that 91% number right there. That's a stat that you don't see a lot in studies. That's a pretty compelling number. And it's also remarkable because these patients paid out of pocket for this treatment, and yet they're still reporting over 90% success. Okay. Then there's another slide, and if you want to show that one, and it's showing 92% still are satisfied at 12 months. So once again, this is an injection. It's done in our clinics. The processing takes about 15 minutes. And the injection is 5 minutes or so. There's some variability here, but it's a quick injection. If I can trade 20 minutes of my time at a doctor's office to get somewhere around 12 months of relief, and there's really no risk of with the procedure, I'll take that every day. And so that's what separates PRP from all the other injections that I mentioned on that other slide. It's much safer than any surgery that a surgeon could offer you. And so, to me, the reason why I would consider it for my shoulder, my knee, whatever, is because there's really not a big downside. It's like, why not try it? You know?
That's really the point. You may have, those watching may have noticed that there was close to a 50% reduction in pain for at 18 months for a good number of those patients. Now, obviously, and you mentioned it earlier, Dr. Wilkins, would be foolish to sit here and make claims like, oh, you're going to get this percent recovery or what have you. It just doesn't work like that. But what we are seeing is a trend towards people being very happy and getting really good relief from these treatments.
Yeah, I mean, I've got a big toolkit that I use, and a lot of my colleagues do. We take pride in adding treatment options at Spine Team Texas, cutting edge solutions. That's what we're all about. And so I can honestly say that of everything that I offer in my repertoire, so to speak, I mean, I don't think I have any more faith in these treatments. I have the most faith. I have the most faith in the PRP option.
Incredible.
Absolutely.
So I guess the question would be, how would people find out and get more information?
Yeah.
So,
So there's a QR code if it'll pop
um,
up. Yeah. Everyone is. We have self-scheduling options, which it doesn't get any more convenient than that. Like I said, 11 locations across DFW. So yeah, I'd love to hear from you. Don't hesitate to reach out to us. You can set up your own visit. You know, that's about as easy as it gets right there.
so this is how you would communicate with Spine Team. Of course, you can call in and get hold of them in any other way that you have been. If anybody at this point has any questions, it would be quite useful. I've actually was emailed a question by somebody that's on the call today, so I'll start with that one if that's okay with you, Dr. Wilkins. This is from Stephanie. Can you do both of my knees at the same time? So that's a question from Stephanie: is can you inject both knees at the same time, or would you prefer stagger it? How would you do that?
Yeah, yeah. So I guess the way we categorize this, doing both knees, I guess Stephanie, you kind of get a BOGO. So yeah, so we would treat both knees. It's the same price. There's no additional fee for treating the other knee. It's a flat rate. You're paying for the product. It's what you're paying for. And so the answer is a resounding yes. We can treat both your knees. Not a problem.
Okay, that's great. And then, as I said, I've got another question here. Just making sure you can see my screen because that's where the QR code is. But the next question is from JT again. Uh, I have Medicare. Will they ever pay for my hips? And if not, how much would this likely cost me?
Yeah, that's a big question. Like I said earlier, this is so minimally processed that it's not considered a drug. So that has creates some restrictions, of course, on the coverage end because Medicare does not cover it, and insurances, commercial insurance, private insurances don't cover it either. I don't know if it's ever going to get covered. Um, the price, it's a bundled price, so you're paying for the product once again. So an initial injection ends up being about $1,000, and repeats are $800, and every other repeat is going to be $800 subsequently after that. And I know that money means different things to different people. Um, this is the cheapest price you'll find in the area, and it's for the best product that's available on the market. And so we stand by that. We stand by the product. It's fantastic, and those studies showed that there was a 90% satisfactory rate, despite every one of those 6,000 patients also paying out of pocket for it.
Yeah, it's a really important point. And as you were explaining that, Ayla and a couple of other people also asked the same question. So obviously that's the burning question. We have a different question here from R. How many injections would you typically need for this to work?
Yeah. So in the studies that were mentioned earlier, there's an average about 1.8 injections, I believe. So some conditions definitely take more than one, and I like to separate those about a month apart. But a lot of less severe issues, and maybe just didn't respond to therapy and steroids, Like an area like the lateral epicondyle, tennis elbow, golfer's elbow, joints of the hands, the ankle, the foot. They can we can see success, and I commonly see success starting in a few weeks with just one injection. So smaller areas, less pathology or abnormality, can see good results in as little as one injection. If it's more severe, then it may take more than one. And data has shown, I think a paper came out last year showing that for certain knee conditions, 3 is better than 1. 5 is not necessarily better than 3. So 3 kind of becomes a sweet spot. And these are for pretty severe knee arthritis conditions. You're looking at, sometimes on the moderate to moderate severe category.
That's actually one of the questions is Ayla again has asked, do you recommend this treatment? The question really is, at what point is it no longer beneficial? So she's mentioned this thing called bone on bone, which is
Yeah.
very, very advanced. That was the, if you remember on the scale, that was the furthest end, the one where we
Yeah.
saw the bone spurs. Is it valuable at that point, or is it better to get it earlier than that?
Yeah, I definitely recommend not waiting that long. And so that's where the information aspect of this webinar comes in. I'm now informing you guys, everyone on this call, I'm giving you the ammunition to make a decision, hopefully before it gets to that point to where it's too severe. Um, having said that, there are other treatment options that are getting a lot of attention. I'm not going to get into it, but just to mention it, there's bone marrow aspirate concentrate. Okay, it's a more potent solution that we do offer at Spine Team as well. And there's data showing that for those severe conditions, it can be tremendously helpful. Um, I'm not saying that PRP doesn't have a place. I still recommend trying it if you can. Okay, because like I said, the alternative may be surgery that you don't want or you don't qualify for, and so you get into that helpless state. I do have patients that have severe arthritis, and it's at that grade 4 that the picture showed, and they have responded well to PRP. It did take them 3 injections, but they have responded well. I have more than one patient. I have several patients that have severe arthritis. So um, it's better at treating the mild to moderate degree, but it is certainly an option, a valid option worth discussing if you have severe.
Great, thank you. Are you all right to answer a couple more questions? Because people are already, these are good ones now. Are we
Yeah,
okay for time?
go ahead.
Oh, side effects, recovery period. That's from Mickey.
Yeah, so there's side effects and then there's associated risks that are inherent to the actual injectate. And so there are no risk inherent to the injectate. It's your blood. It's minimally processed. So there's no risk with that. It doesn't have the same physiologic effects of steroid. Um, and then let me just say that it stands alone. It's very unique in that category. There's side effects of any injection. Okay, so that's where it's similar to any other injection you could get, the gel injection or the steroid, and that comes down to maybe a little slight discomfort at the injection site, not severe. The injection's not aggressive. We're just putting it gently into a desired location with a small gauge needle. It's not a big deal. You can maybe have some redness at the injection site. Like I said, a little tenderness, maybe a little swelling. It may, in the next morning, you may have a little more tenderness, and it starts to subside. And then we start to seeing some effects of it, positive effects at the 2 to 3 week mark. And the important thing to note is that the healing process continues for the next 12 months, at least. I mean, that's at least. And so it doesn't, it starts to plateau at some point, but this is with one injection. So that's where we see some pretty compelling results for folks that's ongoing. And that's where this therapy really excels over the gel injections or steroids.
It's absolutely been my experience. The injections themselves are benign. You don't really feel much. The next day, you're going to feel it. You're going to be sore, but it's not the end of the world. It's
Yeah.
sore rather than pain. And quite honestly, and again, I've had quite a few of these. Then there's a period where you think you wasted your money because it takes 2 or 3 weeks for them to kick in, which is very different to a steroid, which is almost instant.
Yeah. It's going
But
to be
then when
immediate.
it, yeah,
Yeah, it's going to be immediate. Yeah.
yeah. We've got questions, but they're very specific and they're about specific injuries people have got. There's that I will say without, I don't want to mention because of HIPAA, I think it would be inappropriate to start talking about people's specific pathologies, but everybody that mentioned in their questions, could this help? The answer is yes. And it's definitely worth arranging to sit down and talk to Dr. Wilkins or his team about it, because it's not just the joints, and a couple of questions now are becoming about soft tissue and so on.
Yeah.
You know, we are going to be doing a few more of these webinars as well, talking about different sort of, we call it pathologies or different illnesses and diseases. So perhaps we'll spare that. But for everybody, and there's a few of you now that are asking very specific questions, we don't want to get into the weeds. The answer is yeah, everything you've talked about in these questions is relevant. So if you wrote that question, you know who you are.
Yeah, and there's more data coming out every year, and these studies are showing tremendous results for, I'm sure, a lot of the conditions that people are asking about, and so it's just pushing this field forward, the realm of regenerative treatment options.
Well, listen, I think we've kept everybody on here long enough. I recognize it's, it's your evening and people are probably glazing over at this point. I just want to say a huge thank you, Dr. Wilkins. That was an incredible, very informative presentation. Thanks for going through OA and giving us some idea of some of the treatments that are out there. So thank you for that.
Oh no, hey, love doing it. Thank you, Andy, for your effort with this. Tremendous. I really enjoyed it. For the folks out there listening, don't hesitate to reach out to us if you want more information about PRP, or if you just want to ask questions about your health in general. You have something that hurts you. Just remember, Spine Team Texas, we definitely treat much more than just spines. And like Andy said, we'll be doing other webinars in the future, looking at tendon issues, looking at spine conditions that can be treated with PRP as well. I know there's a lot of pickleball players and golfers out there. So if you got some tennis elbow issues, some plantar fasciitis, we'll be talking about that in the future. So be on the lookout for those. I certainly hope I don't see you guys, the ones on the call. That means you've gotten better and you don't need any of this stuff. But if you happen to see me or you see one of my colleagues, rest assured we'll take good care of you. Thanks a lot, guys.
Thanks, that's what it is. Good night.
All right.